Hello, everyone, and thank you for joining the Building Community Resilience Collaborative's webinar entitled Implementing the Family First Prevention Services Act, What Public Health Professionals and Advocates Should Know. I'm Jeff Hild. I'm the Policy Director at the Redstone Center at the George Washington University School of Public Health and the Building Community Resilience Collaborative, or BCR as we call it. We have a great group of presenters for you today, and we're so glad that all of you could join us. One quick bit of housekeeping. All participants except for the panelists are muted, but we want you all to ask lots of questions. So to do so, you'll see a chat box, the lower right-hand side of your screen. Please use that as we go along to type in your questions. We'll sort through them as we go and try to get to as many of them as possible, and we've built in plenty of time for Q&A. So before we dive into our presentations, I wanted to provide you all with a brief introduction of BCR and the work that we do. So you go to the next slide, Caitlin. So BCR is a nationwide collaborative and learning network supported by the Doris Duke Charitable Foundation and the Kresge Foundation. And the goal of our collaborative is to bring together diverse sectors to prevent and mitigate what we call the pair of ACEs, or adverse childhood experiences within the context of adverse community environments. And you can see the pair of ACEs tree here. We seek to implement practice, programmatic, and policy changes to create trauma-informed systems that promote equitable, healthy, and resilient families and communities. Next slide, please. So we do work in 5 areas of the country, including Oregon, the greater Dallas community, Washington, D.C., Missouri, and eastern Kansas, and the greater Cincinnati area. And if you'd like to learn more about our work, you can visit go.gwu.edu/BCR. We'll go to the next slide. So here is our agenda for the next 90 minutes. We want you to leave this webinar with 1, a deeper understanding of the Family First Services Prevention, or the Family First Prevention Services Act. We'll just call it Family First from here on. 2, knowledge of what some of the key opportunities and challenges are in implementation of the Act. 3, an understanding of how Family First might interact with other systems that serve children and families, particularly Medicaid. And 4, information that you need to begin or to deepen your engagement in your state or community as the law gets implemented. So we can go to the next slide. So just some quick background. Most of you on this call are going to know this, but in February of last year, Congress passed a bill called the Bipartisan Budget Act. This large bill was the vehicle for passage of Family First, a piece of legislation that most of the presenters you'll hear from today have been working on for many years to get through Congress. And passage of Family First was greeted with cheers from child welfare and foster care advocates and many others who work to improve outcomes for vulnerable children and families. And people are excited because after several years of increasing numbers of children entering foster care, due largely to the substance abuse epidemic in this country, the federal government was starting to take a different approach, one that is more focused on prevention and supporting families in order to keep children safe in their homes, and that for children who do enter foster care, that they are placed in family-like settings to the greatest extent possible. So for public health professionals and other advocates, this law offers new opportunities to work in your state and community to refocus our child welfare system on prevention and strengthening families. We're pleased to share some of those opportunities with you today. So our next presenter is Marlo Nash. Marlo is the National Director of Partnerships and Policy for St. Francis Ministries. Marlo is a leader in the field of child and family policy, and her career spans multiple decades in organizations focused on child well-being. And we asked Marlo to join us today because of her previous work in helping to pass Family First, as well as her current work to help states successfully implement the new law. And she's been traveling extensively, talking with stakeholders about the law, and we're lucky she'll be sharing some of her expertise and unique perspective with us today. And so, again, I'd remind folks to enter questions in the chat box as we go along, and Marlo and I will pause periodically to get to those questions. And someone did have a question about slides. The slides for Marlo's presentation and Jessica's later, we will make those available after the webinar. The congressional slides, unfortunately, are not going to be available. So Marlo, I'm going to turn it over to you.
Thanks, Jeff. It's such a pleasure to be with all of you and to be representing St. Francis Ministries. I just tell you a little bit more about our organization. We are a national and international organization providing services and supports to children and families to build child and family well-being in several states in the Midwest. We're headquartered in Kansas. We're also working nationally as a human services solutions provider and a partner in policy advocacy and systems change. So we're working in a number of states, some where we are present as a provider of services and others where we are just coming alongside and helping states figure out how to implement Family First, as well as working on other issues, but that's our topic of focus today, so I'll focus in on that. So as I'm talking, just know that I'm available through my role with St. Francis Ministries to continue to be in conversation with you, to provide technical assistance and consultation on anything that I cover today that might be of interest. So we're all here today because we see and value the potential that lives in all children and families, and we recognize that supporting policies and programs that activate that potential will lead to the kind of healthy and thriving communities that we all want to live in. The Family First Prevention Services Act, as you just heard from our congressional leaders, is a landmark federal child welfare law that could have a profound effect on the way states build, maintain, and repair well-being for children and families. So what I'm going to do in the time that I have, and as Jeff said, we're going to try to leave time for questions and answers, so please send those as you have them. I'm going to hit some of the highlights of the law very briefly, just because I know that for some of you, this is your first orientation of Family First, and much of the rest of my comments are going to be related to some key points about the law. So I know the congressional staff just went over it, so I'm not going to dwell on it, but I do just kind of want to hit some things, especially for those of you who are hearing it for the first time, to help it kind of sink in and connect up to what I'm going to share thereafter. The second part of my presentation will really be focused on some points that I've kind of culled out of both the Family First law, the guidance that has come out from the administration, and what I'm observing happening in states across the country with the Building Community Resilience Collaborative and Network in mind. So there's kind of a cross-section that I did to come up with the things that I'll touch on later. And so I'm going to overview some points, and then I'm going to dig deeper into some of those points to talk about some specific ideas that I have for roles that you all could play. So I'm hoping all of that is helpful in kind of grasping some gaps and opportunities that you may be able to step into given the work that you're doing in collaboration on the ground. So first, the quick overview. So there are many provisions actually in the Family First Prevention Services Act, as it ended up being an omnibus child welfare law. But there are two key provisions, and one is the 4E prevention program, and that's the work to invest in prevention and in supporting families. And I do want to emphasize, as you hear the title, Family First Prevention Services Act, and hear the term prevention in the context of the Family First Prevention Services Act, always remember that prevention in this context refers to preventing children from entering foster care. And I want to emphasize that because it's very important as you educate and as you advocate to other stakeholders and decision makers that they don't get confused and think this law is about preventing child maltreatment, because this law steps in after child maltreatment has occurred. So there's still a lot of work to be done in primary prevention and addressing root causes, which I know is a strong emphasis of this network. So next slide. So the candidates for the program are those children who are identified as being an imminent risk of entering foster care, but also identified as potentially safely remaining at home with their parents or with kin caregivers if they have Family First supports. These include children whose adoption or guardianship or is at risk of disruption or dissolution. It includes, this is important, it includes the kinship caregivers and or the parents. They can receive services, and in a state, for example, in Kansas, they are saying, and we will define family as the family defines family. So those members of the family that the family that they're working with includes as family are all eligible for services and supports that help keep the family together. And then the other candidate population is pregnant or parenting foster youth. So what I want to say about, well, I'll say that in a minute. I'll go ahead and stick with the overview now just to not interrupt myself as we go along. Okay, next slide. So some key points about the prevention program are there are 3 categories of evidence-based practices that can be provided in the area of mental health treatment, substance abuse prevention and treatment, in-home parent skill-based programs, including individual and family counseling, that they can endure for 12 months and that they are then renewable, and a family can receive multiple services at one time within that 12-month period, and then they can receive them really in perpetuity if the case manager can keep making the case that if they are provided these services, they can stay together as a family. There's no income eligibility, which is significant in that it opens the candidate pool wider than if there were income restrictions, but it also relieves the system of a costly and time burden process of identifying income eligibility. So it was important, one, to say, let's put resources directly toward families and not trying to, exclude some families based on income. And then the clearinghouse, which the congressional staff talked extensively about, but I think the most important thing to remember, and I think sometimes people get tripped up because there are other clearinghouses that already exist, is that only evidence-based practices that are included in the federal 4E Prevention Services Clearinghouse are eligible for the reimbursement through Family First. So that's important to remember. Next slide. And then the second key provision that I'll reference today, and I'll reference it as the congregate care provisions, is that whole section of the law that is about the congregate care settings that are allowed, that federal financing will reimburse for. So it's important to remember on the congregate care provisions that they only apply to 4E income eligible children, which raises a question for states as to, whether or not they think these provisions are valuable for the general child foster care population, and should they be applied broadly, or should they just apply them for 4E income eligible children. So that's an important distinction on that aspect of the law, and it's federal reimbursement to these specified settings. So if you go to the next slide, and the congressional staff went over these, so I'm just going to highlight quickly. So a foster family home can be reimbursed with federal funding. The other specified settings are the Qualified Residential Treatment Program, which is the most significant new development in the Family First Act. So you've probably heard a lot about that in your states, even if you've never worked in congregate care on the child welfare side at all. It's much talked about, big change. So QRTPs, the settings that specialize in serving pregnant and parenting youth, the residential setting for youth have found to be or at risk of becoming sex trafficking victims, the supervised settings for youth ages 18 and older who are living independently, and then the licensed residential family-based substance abuse treatment facility, and for that one there's no income test. You may hear more about that one because it's causing some energy in states to think about, can we offer more of these kind of programs now that there's a federal reimbursement that helps the children stay with the parent or parents when they're getting substance use treatment. Okay, so that completes the quick reiteration of points, and we'll move to the next slide. So this next section is these are the pieces that I've kind of pulled forward with this network, particularly in mind. So as I go through these, and I'm going to go, it's a lot of material to cover quickly because my concept today is to just plant many seeds for your thinking and hopefully for your questions. But what I want you to be thinking about as I'm going through this is, how can Building Community Resilience Network leaders engage as partners, learners, teachers, cross-sector leaders, advocates, et cetera? There is a tremendous opportunity to bring the BCR framework and approach to realize a system of child and family well-being in your states. And what I'm going to try to do is point out where some of those opportunities are. So next slide. So the law requires a trauma-informed approach on the for the 4E prevention program, and also on the congregate care side, it requires that the QRTP chooses a trauma, excuse me, a trauma-informed treatment model. But on the 4E prevention program, the law defines trauma-informed approach in this way. The services or programs to be provided to or on behalf of a child are provided under an organizational structure and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma and in accordance with recognized principles of a trauma-informed approach and trauma-specific interventions to address trauma's consequences and facilitate healing. So in the I think, and I'll talk more about this in a minute, I just want to plant in your thinking that the way the BCR network thinks about trauma, what you know about trauma, and how committed and focused you are to trauma-informed approaches, I think there is a tremendous opportunity for you to step in and be a partner, come alongside those who are implementing. And again, I'll talk more about why I think that is in a minute, but I just want to go over these kind of key things for you to be thinking about, and then we'll double back on some of them. The opportunity to move further upstream, I want to encourage you to think about Family First as a locus of opportunity to establish a framework of principles and desired outcomes that begin with addressing the pair of ACEs, so addressing adverse childhood experiences, preventing and mitigating, and adverse community experiences, to addressing the root cause to child maltreatment and providing greater prevention services. So Family First, the law itself does not do that because it focuses, it comes into play after child maltreatment has occurred. However, there's quite a bit in the law that if you think about Family First as sort of a center of energy and a place to start, but think about a network like yours being able to think, so how can we spin that energy out and have it go more and more upstream? What are the ways that we can do that? You have knowledge and experience and frameworks that can help your states do that kind of work. And many of the child welfare departments, understandably so, are technically focused right now. There are many deadlines and many complexities to implementing the Family First law. So while some of them are know the opportunity here, their plates are full and they need to have other partners. So I just want to read the foreword to you from the Administration for Children and Families when they issued guidance on the prevention program. And I think it's the last thing I'm going to read to you word for word, but I do want you to hear how the administration is talking to the states about this opportunity with that idea of Family First as sort of a place to start to do something even bigger. So the foreword to the program guidance for 4E prevention program reads like this. The creation of the Title 4E prevention program is an unprecedented step in recognizing the importance of working with children and families to prevent the need for foster care placement and the trauma of unnecessary parent-child separation. The Title 4E prevention program is part of a much broader vision of strengthening families by preventing child maltreatment, unnecessary removal of children from their families, and homelessness among youth. It provides an opportunity for states to dramatically rethink how they serve children and families. It creates an impetus to focus attention on prevention and strengthening families as our primary goals rather than foster care placement as our main intervention. The Children's Bureau strongly encourages all states to take this opportunity to not only use the Title 4E prevention program to fund these important services, meaning the evidence-based practices, but also to envision and advance a vastly improved way of serving children and families, one that focuses on strengthening their protective and nurturing capacities instead of separating them. So I want to just reemphasize before I move on that is contextual statement. That's wrapping a context around the direct provisions of the law, which are not about primary prevention, but this is the Children's Bureau and many others of us really encouraging that this be an opportunity to make 1 + 1 = 3, if you will. So family engagement and family treatment is a running theme through the Family First Act. And it's important to recognize that this is, for many, many stakeholders and decision makers in the child welfare system, is a reorientation of a system that has been very child-focused. In some ways, it's child-focused just practically, it just is how the system has been set up. In some ways, in other ways, and for other stakeholders and decision makers, it's child-focused because they have an anti-birth family kind of approach, and that the sense that the family should be punished for what they've done to the children. So rather than thinking about it in terms of they think about it in terms of what did you do as a parent versus what's happening to you or what happened to you. And I think Family First Prevention Services Act takes that view of saying what's happening here, what's happened to you, and can we intervene in a way that strengthens the family and keeps the family together. So there's a real family emphasis, but it's going to take some time for a culture to develop around really treating the whole family and the opportunity that is provided to treat the whole family. And on the congregate care side, there's a real emphasis on family engagement as well. So families are to be engaged when assessing a child as to whether or not they need to be in a QRTP. There's a requirement in the law for a family and permanency team to be involved in that. And then there's a requirement in the law that the QRTP programs demonstrate how they're engaging families. So a real family emphasis. Flexibility for states. So there's much prescribed in the law, but there's also a lot of flexibility given either through the law or as a result of how guidance was provided by the Administration for Children and Families. So for example, candidate for care is defined in some ways in the law, but the administration came out with guidance and said, we're not defining it further. And there's sort of an implication there that states can be thinking, how would they define candidate for care more broadly? And so examples that I've heard are, some states are thinking about, can we say, does it make sense to say if a spouse is identified as a victim of domestic violence, can we assume the kids are candidates for care so that we can wrap services around the family and really help heal and protect them? Another example I've heard in states is that children who are part of the nurse or families who are part of the Nurse-Family Partnership home visitation program, by definition, that program sees pregnant mothers who have, who haven't gone beyond a certain point of their pregnancy and are having their first child. But the data shows that those children, unfortunately, even though they benefit from that program, they also still go into foster care at a higher rate. So the question is, could you automatically consider those unborn children as candidates for care so that you could wrap services around the mother while she's pregnant that are more than just the Nurse-Family Partnership, but other services that could be reimbursed by 4E, so substance use services or mental health services if those were appropriate in the family's case. Proxies for quality. So there are a couple places where the congressional staff talked about this, where there was, the federal government didn't want to just pay for changes or just put money out there. They wanted to really guide changes. And so those proxies for quality, the use of evidence-based practices, and the program accreditation for QRTP, I would just say in both cases, in the use of evidence-based practice, it's very important, as I think you all know, that an evidence-based approach is guided by implementation science and that there's real commitment to having fidelity to the model. And so you want to disavow folks of the notion that they can just, become a partner with a purveyor of an evidence-based practice and kind of do it in name only. It's very rigorous, and that's the only way that you get the outcomes. And so this whole, again, contextual wraparound that there needs to be an evidence-based approach within the system, not just, churning out evidence-based practices. And on the QRTP side, program accreditation is definitely an indicator of quality, but those of you who are in accredited programs know that it's the day in, day out decisions, case by case, how everything is handled that really fulfills that promise of quality that achieving accreditation, sort of indicates for a program. So it's a very organic living kind of thing. So it's a proxy for quality, but there's still a lot that has to go into that. And so there's got to be thinking about this from the system on how does the system support the ongoing quality of accredited programs. Congregate care provisions are complex. You may have heard a lot about accreditation because there's a burden on the accrediting bodies right now to try to quickly help programs get accredited. It takes time to get accredited. What if a program doesn't achieve accreditation? Are they still going to be needed in the state? So if you are connected with provider organizations, you may have heard some of these conversations. Foster family recruitment and retention is a really important component of this shift around congregate care, as is having a robust array of home and community-based services for those kids that are deemed to be able to be in foster family homes, but we know still very likely need treatment. They just don't necessarily need it in a residential setting. So the states are assessing their needs for congregate care. How much QRTP care do they need? But that even gets complex, because as they do, enact the prevention program and keep more kids with families, they've got to figure out over time how that may affect their need for group or congregate care, and how they may end up, in the future ramping down. So those are all things that I know the states are thinking about, and also providers are asking about and wondering about, and doing the internal work and the business planning that's required for this kind of monumental change. And then last overarching point is there's an emphasis on consultation and coordination across systems, which I know is important for this group, and that you all actually are getting, in many cases already, are growing your capacity to make this happen, and really practical understanding of what it means to work across systems. So I want to pull up for you or call out for you that there's an emphasis in here, and that it could even go further than in practice, and it's being emphasized in the law and by the administration. But the administration did issue guidance, and this is guidance specific to the 4E prevention program, that says a state must describe, number one, how it will consult with other state agencies responsible for administering health programs, including mental health and substance abuse prevention and treatment services, and with other public and private agencies with experience in administering child and family services, including community-based organizations, in order to foster a continuum of care for children, parents, and caregivers receiving prevention services. And number two, how the prevention services provided for or on behalf of a child and the parents or caregivers of the child will be coordinated with other child and family services provided to the child and the parents or caregivers of the child. So I'm going to pause there. This will say the next section is giving you some practical ideas of things that you can do, but I want to see if there are questions before we move to that.
So Marlo, I think the one question that came in around how we're defining a child who's at risk of entering the foster care system, I think you touched on that already. And just to clarify for that questioner, is that the state has pretty great flexibility in defining that. So if there's anything else you'd want to add there, fine, and if not, I think we can keep moving.
The only thing I would add is that I'm sort of seeing that states are it's seeming like to get started, especially those that are trying to initiate Family First at the earliest possible initiation date, which is October 1st, 2019. It's seeming like they're kind of going with the definition for the candidate population as it is now, but that I think what I want to lift up to you all is that there's opportunity over time to work with the state to try to expand that candidate population. So I wouldn't get discouraged if your state is starting out by saying, we're only going to look at those that are defined in the federal law as being candidates. But to think about your populations, who you work with, and who else might be benefit that you could make the case for, and so this may be something over time to expand the candidate pool. And I'm going to touch on that again in just a minute. But so is that the only question?
Yeah. So that looks like it's it for now.
Okay. So I see your note. I have about 5 minutes to run through some practical. You can move the slide, and I'll try to just hit some key points. Because like I said, I tried to make these practical suggestions mirror the kind of overview that I just did of some of the key things that I wanted to encourage you all to be thinking about. So a system-wide, multi-system trauma-informed approach, I think there's lots of room for states to define this. I think your network could be tremendously helpful in shining a spotlight on this and showing up as knowledgeable, engaged partners. there's not a lot of what I see is there's not a lot of attention being paid to this right now because there's a real emphasis on the technical parts of the law that have a deadline, and so I think there's time and opportunity to work in this space. On the opportunity to move further upstream, I think there's tremendous opportunity for BCR network because I think that adaptive leadership is needed. While there's a lot of demand on the child welfare system to think technically, there's a lot of opportunity to think about what's happening from an adaptive lens and to think about how systems could get integrated, practical ways of involving other systems, framework of principles and outcomes, education and advocacy to help stakeholders and decision makers understand the opportunities to move further upstream, even though the law is very focused in secondary in the secondary space of intervention, to offer a vision for what can happen and to see connections and opportunities among a range of issues. So I think there's a lot that could be you could bring to the work and the conversation there. For meaningful family engagement, I think holding up that this is a time to think holistically and comprehensively about the family needs because now there's the opportunity to actually provide services. And I appreciate that the congressional staff pointed out, that these can be services provided by other agencies, not just the Child Welfare Agency. So really encourage those who provide substance use treatment and mental health services to adults and maybe have never served children, now have a space to serve families. And that, the conversation and the connections and the partnering needed to do that are really important and valuable right now. Areas of state flexibility that are opportunities. I talked about this before. I do want to touch on this again just because of the question that came about candidates for care. I do want to point out that part of the challenge is that Family First it has a carrot, but it also has a stick. So families can get these robust, beneficial services, and they can get an array of them all at one time. But they can only get them if it's already been identified that if they fail these services, their children are likely to go into foster care. So we're not quite to that idea of a family resource system where a family might self-select themselves into that system. But it is a starting point for thinking about how could we get to that point of a family resource system or a system of child and family well-being, and what additional resources, additional thinking, connecting, how can we provide overlay the trauma-informed lens. So at a meeting I was at the other day, the suggestion was, let's not make the only call-in line a child abuse hotline. Let's make a warm line and make, a different entry point. And the person who raised the idea said that's, they saw that as a trauma-informed approach. So that's the kind of thinking I'm talking about. Evidence-based practice, delivery, and development. So the congressional staff touched on this about how if you've got practices and you want to get them on the evidence-based path, that you should do that. They're going to be growing the clearinghouse on a rolling basis, and there are going to be gaps in what situations evidence-based practices address now. For example, and I haven't dug deeply in this, but I was in a conversation the other day where we were realizing that there really aren't evidence-based practices outside of Kinship Navigator that are specific to relative caregivers. So there are some that might apply. They might be designed for parents but apply to relative caregivers. But, it seems like a lot more could be done to really specifically think about relative caregivers and how, we could drive better outcomes for those situations. Education of stakeholders and advocacy are necessary. There's a breakthrough in that Family First brings providers of adult services into the equation now for serving families, but I don't think I think there's a lot more educating to do to help people realize that that's what's happening, and all the new thinking and partnerships and opportunities for knowledge sharing and working together. The governors and legislatures need to understand that there's a state investment in drawing down the match, and then they also need to understand the idea that we will want to reinvest dollars that are realized out of the foster care system when children are safely with their families, and we want to reinvest those in the evidence-based practices, but over time perhaps even reinvest them in primary prevention. So they need education to understand how all of that can happen. They need to hear that Family First is a part of the state's response to the state's substance use crisis. We know that that's a top-of-mind issue for many state legislators and governors, and if we can connect Family First to that and say, include this in the overall picture of what the state's putting together to address this, then there's leverage there. Many judges need to be reoriented to a keeping families together approach versus a punishing families approach, and so there's education to do there. There's education to connect early childhood and child welfare, to connect housing and child welfare. There's so much opportunity, but it starts with stakeholders and all those systems understanding what's going on and how they can play a role and how new partnerships can happen. And the last point I'll just quickly make is there's the option for states to delay implementation. I told you the earliest start date is October 1st, 2019. The latest start date is October 1st, 2021. The trigger is if the state is prepared to implement the congregate care provision. So in order to start the prevention program, they have to have their congregate care in line with the federal law, or they have to decide they're going to forego federal reimbursement on the congregate care side in order to start the prevention program earlier. So I would just urge you to be in conversation with your state to really think about the financial benefits of starting the prevention program earlier, even if they have to cover some of the cost on the congregate care side. And I'm going to wrap up now, but I'm happy to talk more about that. It's fairly complex, but the point I want to leave you with is be an advocate in your state for not overwaiting to start implementing Family First, because there are ways to think through that and work through some of what seem like barriers, but don't have to be barriers to implementing sooner rather than later.
Great, thanks so much, Marlo, and that's wonderful advice for folks thinking about their work at the state level. And as Marlo mentioned, she's a resource for you all, and so if you feel free to get in touch with her directly or get in touch with me and I'll connect you. So next we're going to move and talk a little bit about how Family First and Medicaid and the Children's Health Insurance Program might interact and some of the questions that we should be thinking about moving forward. So our presenter is Jessica Schubel. Jessica is a senior policy analyst at the Center for Budget and Policy Priorities here in DC. She's an expert on both Medicaid and CHIP. She's worked at the federal level at CMS, the Centers for Medicaid or Medicare and Medicaid Services, and also at the state and local level at DC's Department of Healthcare Finance, which is our local Medicaid agency here in DC. And we also really like Jessica because she received her Master's of Public Health from George Washington University. Jessica, take it away.
Thank you so much, Jeff. Good afternoon, everyone. So I wanted to talk a little bit about Medicaid and Family First, what we know and what we don't know. I am not a child welfare expert by any means. I am a Medicaid person, and so wanted to just make sure that we were all on the same page with respect to what Medicaid and CHIP coverage looks like for kids, although I'm primarily going to be focused on Medicaid. So next slide, please. So as I mentioned in the agenda, we're just going to talk about children's coverage in Medicaid and CHIP, Medicaid and Family First, what we know, and then moving forward, what things we should be considering. Next, please. So children's coverage in Medicaid and CHIP, as you can see, Medicaid and CHIP play an important and significant role in covering children. Nearly 40% are enrolled in either Medicaid and CHIP. And studies show Medicaid has a significant and positive impact on children's long-term development and health. Studies have shown that children covered by Medicaid during their childhood have better health as adults, with fewer hospitalizations and emergency room visits. And these kids are also more likely to graduate from high school and college, have higher wages, and pay more in taxes. So Medicaid is an important and a significant player in children's development. Next, please. I wanted to talk a little bit about kind of the various coverage pathways. In Medicaid, there's multiple pathways for eligibility. Two groups I wanted to highlight are the mandatory groups. So children receiving, what we call the 4E kids and children under 19 with incomes below 138% are mandatory children. That means that the states have to cover these kids. And for those that are somewhat familiar with children's Medicaid eligibility, before the Affordable Care Act, there was this what we called stair-step eligibility, and eligibility for kids was based off of how old they were or are. But the Affordable Care Act eliminated that, so the eligibility level is consistent across all ages, and that's set at 138%. So for the second pathway in Medicaid is optional. As it sounds, it's up to the states to elect whether to implement those pathways. So I would just flag for people that you should check your state Medicaid program's eligibility because, as the old adage says, when you've seen one Medicaid program, you've seen one Medicaid program. Some states cover young adults aged 19 and 20. Some might have higher eligibility levels, might go up above the 138. And for kids with disabilities or special health care needs, there are optional pathways through the Katie Beckett waiver program or through some other home and community-based services waiver. I am not, my love is with Medicaid, and so with CHIP, I'm just kind of going to briefly mention, and CHIP covers children not eligible for Medicaid because their family income exceeds the Medicaid eligibility threshold. So they have the CHIP program has higher eligibility levels. And states have the option to either create a standalone or separate CHIP program, or they could simply kind of make it a Medicaid expansion. So again, would look at your state-specific program to figure out which option your state has selected. And I just threw in this nice map of the U.S. that shows the eligibility levels for kids in Medicaid and CHIP, and just for your references. Next slide, please. So children's, just kind of wanted to talk a little bit about the important protections in Medicaid and CHIP. In Medicaid, there are no premiums or cost sharing for children. And then you've probably heard of, the gold standard benefit, which is EPSCT. And I spelled it out for you here. It's early and periodic screening, so that's the EPS. The D is diagnostic, and the T is treatment. So what does that mean, and what's covered? Sorry, I wanted to get my notes here. The key is that states must cover all of the mandatory and optional Medicaid services that are in the Medicaid state plan. So, for example, some of the screening services are a comprehensive health and development history, a physical exam, lab tests, vision services, dental services, hearing services, any other necessary healthcare service that's found to be medically necessary to treat, correct, or reduce illnesses and conditions discovered, regardless of whether the service is covered in the Medicaid state plan. So that's key. That's why I said the key point here is that all mandatory and optional services in Medicaid need to be covered. The diagnostic piece is if a screening examination indicates that further evaluation is needed, states must provide those diagnostic services. And then again, for treatment, all physical and mental illnesses or conditions discovered by any screening or diagnostic procedure must be treated, regardless of whether the health services for such treatment are otherwise covered under the Medicaid state plan. In CHIP, the premiums and cost sharing are permissible, so it's not quite as protective on the affordability side as Medicaid. In CHIP, there's no EPSDT guarantee, so benefit packages might look a little bit different. And I guess one other point I forgot to make on the EPSDT piece is that I'm not sure if you caught that they simply need to be medically necessary. They don't need to be evidence-based, and I think that's key, and I can talk a little bit more about that in a few minutes, but I think that's key when you think about how Medicaid interacts with Family First. Next slide, please. So, not to be glib or flippant about this with my GIF here, but what we know, it's a little bit, we don't know too much. We haven't seen any guidance come out from the Centers for Medicaid and Medicaid Services. If you could click it one more time for me. So as other folks have mentioned earlier, the Family First is the payer of last resort. So that means if Medicaid is supposed to pay for a service, and this really applies to kids because of the EPSDT guarantee, Medicaid and CHIP need to go first in terms of reimbursement. Click it one more time, please. And finally, just wanted to flag Medicaid's IMD exclusion does appear to apply to the QRTPs. That means that there's no Medicaid dollars that can go to facilities, residential facilities that have 16 or more beds. So that's something that, worth considering as we move forward in terms of the interaction between Medicaid and Family First. Next slide. Moving forward, things to consider. Medicaid expansion, I know we're talking about adult coverage here, but it's something worthwhile to think through since Family First does include parental, will pay for services provided to parents. Just flagging that 37 states have adopted expansion, 14 have not. Next slide, please. And the reason why that I mention this is just that, as we've seen, the uninsured rate gap between Medicaid expansion states and others are widening. So it's something to think through as we are, talking about what services that can be provided to parents through Family First versus Medicaid. Next slide. And again, just talking about how that Medicaid expansion impacts kids. Research shows that children are more likely to be insured if their parents have coverage. As our graph shows here, children are more likely to get a well child visit if a parent is enrolled in Medicaid. So again, linking just the importance of having parents covered and what that does for the family. Families are more financially secure. That helps make sure that kids are less likely to be negatively affected by issues resulting from poverty, such as toxic stress. And healthy parents help ensure that their children's health and development is strong. And so that's why it's important, one of the reasons why it's important for parents to have coverage. Next slide. So again, thinking through various questions in light of the fact that we don't have a ton of guidance coming out of CMS at this point. But as you are thinking about how to best engage and moving forward with Family First and its implementation and what that means with Medicaid, I would think, again, think about the eligibility components. You know, has your state expanded? Has it not? What's the coverage look like for kids, eligibility? Same with the CHIP, the benefit package. You know, are there specific mental health services that are covered or not covered? I will say just on that point that it's sometimes tricky to find, to go through a state's Medicaid state plan. They're not the easiest things to read, and to figure out what's covered and what's not. So just something to think through. Kaiser Family Foundation does a great job of trying to list out through their various survey reports what's covered and what's not. And one other consideration is just kind of the managed care versus a fee-for-service delivery system in Medicaid. Our managed care plan is going to have to be involved as you know, states implement or take up Family First and work with coordinating with Medicaid. The other component I just want to flag is, does the state have a Medicaid waiver? CMS is now approving Medicaid waivers that waive the IMD exclusion if a state has, you know, demonstrated that there is a substance use disorder kind of approach that they're taking. So thinking about that, does your state have a Medicaid waiver that restricts eligibility, such as work requirements? Although we got good news yesterday afternoon. So things in Kentucky and Arkansas are on pause there. But again, thinking through what's the state of play with your Medicaid program. And then finally, I'm not sure if folks have seen recently, but the CMS's Innovation Center has issued an integrated care model for kids. And that is a new opportunity for up to 8 states. The model is a child-centered local service delivery and state payment model that aims to reduce expenditures and improve the quality of care for kids under 21 through prevention, early identification, and treatment of behavioral and physical health needs. The participants in this model will be required to integrate care coordination and case management across physical and behavioral health and other local service providers to provide child and family-centered care. So as you can see, there's lots of overlap with kind of the mission of Family First and this new integrated care model. So it's kind of worth thinking through, you know, and again, this is only available for 8 states. Your state might not elect to participate, but just another thing to consider or keep in the back of your mind as your state moves forward. So I know it was quick, but I wanted to try and get through everything in the time allotted, but also wanted to leave a little time for some questions if folks had any.
Great, thanks, Jessica. I think this question is aimed towards you, but Marlo may have some insight as well. So the question is, if your QRTP is a Medicaid service, what 4E or foster care dollars can you draw down for the service since it's the payer of last resort? Any thoughts on that one?
So I can try and take it. I think that if the QRTP, you know, is not deemed to be an IMD, Medicaid would certainly pay for that service. If that QRTP, you know, is found to, you know, per CMS's guidance to be an IMD, then that's something, you know, the Medicaid funding wouldn't be available for, and then, you know, states would have to draw down, you know, the Family First dollars or the 4E dollars.
Thanks, and Marlo, I don't know if you're still on, but if you've got any insight there, would welcome it.
Even in the It says I'm muted. Are you able to hear me?
Yep. Yeah, we hear you.
Okay, sorry. I'm getting a message on my computer saying I'm muted. Sorry. What guidance has come out is says that 4E will pay for what 4E typically pays for, which is the room and board, and there, you know, there's kind of a list of things that we could send out to folks
Right.
as follow up. And I think that there's still some clarity to be had around how all of that is going to play out around QRTP and the interplay with 4E.
Right.
Because remember, the 4E, 4E is only for 4E income eligible children. So the income test hasn't changed on the congregate care or foster care side of the equation. So that factors in as well, I think.
Yeah, good point. Well, we're at 2:30 Eastern, so we're going to go ahead and wrap up. This webinar has given me and I think all of us a lot to chew on and think about. We'll send out a follow-up note with the slides that we can make available, as well as a recording of Marlo and Jessica's presentation, some relevant links that folks asked about, particularly to the HHS guidance, and then we'll also send out some other Family First resources. So lots of organizations are putting out resources here. One great one, 0 to 3, has put out around the safe baby court model and how Family First might be used to pay for services there. And there's a couple others that we'll include for you all. And this was really meant as kind of the first one of these for the BCR teams around Family First. And as you heard, there's a bunch of different areas we can kind of get into, and so would love to hear feedback on what folks want more of and where more information would be helpful. And again, I would just really like to thank our panelists today, just great information. We'll also send out everyone's contact info, and thank you all for joining us, and we'll see you next time.